Welcome to this meeting. We have a full meeting for you today, and I'm very pleased. There are about 60 to 70 or more registered for the meeting, so people might be turning up later because of the time zones. We are recording this meeting, so if you don't want your face recorded, you can keep your cameras off. But I think it's always good to have your camera on when you're in the small groups, particularly. In the large group, it's not, but also in these groups, because with Zoom, we don't have the cameras. So I'm Peter Lachman. I'm a pediatrician. I'm one of the founding members of WHLNet. I work with young doctors and clinical teams developing leaders here in Ireland. And I've been working, I used to be the CEO of ISQA a few years ago, and otherwise a pediatrician before that. And I've used my little black book to invite people today to speak to this very important topic about how do leaders lead in this very difficult world we have, which is challenging. And what I thought for today is that we'd go around the world. We're going from India, representing Asia, or subcontinent, then to Africa with Lydia, then to Europe with Mathieu, and then to Latin America and to Peru with Juan. And I'll introduce them as they go along and tell you what they are. But I'm very grateful for them for giving my time. Over to you, Bill.
Terrific, Peter, and good to see so many participants here today. I think it's record-breaking. This is our 7th, I believe, such webinar. And it's my pleasure on behalf of the World Health Leadership Network Steering Group to welcome you to this session. So good morning, good afternoon, good evening from wherever you are in the world. And we have a number of, as you might see, of our steering group members on the call today. Peter's one, Neil Grunberg, Graham Dixon, Kelly Grimes. So I want to welcome you on behalf of the steering group and just underscore what the purpose of the World Health Leadership Network is, and that's leaders supporting leaders to do the best job we can under the circumstances we individually face. And we're going to talk about that today in terms of facing adversity. I'm also here as the founding CEO, Executive Director of the Canadian Health Leadership Network. And the current CEO is Kelly Grimes, and she's on the line this morning. Canadian Health Leadership Network got going about 2009 and is going strong here in Canada with over 40 members. And I guess it kind of inspired in some way the creation of the World Health Leadership Network. Can we do the same to support leaders worldwide? So on behalf of the steering group and on behalf of the CHLNet, I want to welcome you all here today.
And so I'm going to go over to Gaurav. You can introduce yourself, tell them about yourself, and I'm going to turn my watch on. You've got about 8 minutes or so to talk about the challenges facing you in India and adversity. Okay, over to you, Gaurav.
Thank you so much, Dr. Peter. A very hello and a very good morning, afternoon, evening to all of you. Thank you for having me here on this panel today. I'm Gaurav Loria. I represent India. I have been with Apollo Hospitals for almost 18 years now, and I had operations, patient experience, and safety for Apollo Hospitals Group, which is a network of about 75 hospitals, about 250 primary care clinics, 6,000 pharmacies, and we are, in largely all the facets of healthcare. Just to give a very quick brief, I'm also an administrator surveyor and team leader with Joint Commission International, on the board of directors for NABH, which is the national accreditation system here back in India, an expert with ISQA, and also I have few papers and few books to my credit. So with that, that's like a brief or a summary about me. Now, I think jumping onto the topic of confronting adversity and taking on challenges, definitely a very, very apt topic in today's times. I think healthcare landscape has been experiencing unprecedented transformation, shaped by largely pandemic aftershocks that all of us had gone through. There are continuous and persistent inequalities in healthcare systems across. Workforce challenges, which I think everybody's touched with that, and an evolving disease burden. Uh, who can ever forget the kind of pandemic that all of us faced? Sleepless nights, challenges every minute. You don't know what the next call is coming. It's for what? We at hospitals, we saw situations from our nurses who were performing last rites of the patients because either there was nobody left in their families, or whoever was left was not allowed to go and perform the last rites, to sadness and grief all over. uh, it did create a complex web of ongoing healthcare challenges at that point of time, for which we are actually struggling till date. Obviously, there were learnings out of it, but I think there were definitely challenges, and we have been working around to see how we can get out of it and move to the next level in healthcare. The whole care avoidance piece, and a significant backlog that it had created of undiagnosed conditions, unmanaged chronic diseases, young adults about 18 to 24, unpaid caregivers, persons with disabilities who were largely affected, with care avoidance exceed much higher in these groups. These consequences largely, also missed opportunities for chronic disease management, delayed vaccinations, investigations, and care process. And I think one of the most alarming things of this was the whole mental health crisis, which even India is definitely facing for its healthcare workers, as it is a true reality across the world. People suffering with anxiety, depression, it actually increased by 25% in the pandemic's first year. And this is as per some of the statistics that have been published. This mental health burden disproportionately affected young people, women, creating new pressure points, largely in the healthcare systems that already stretched people thin. The other challenge that we face, from an Indian perspective, is definitely the rural-urban divide that deepens the health gaps. So there's a disparity that extends beyond access to actual health outcomes. At all income levels, health does follow a social gradient, but then, the lower the socioeconomic position, the worse the health outcomes happen. So it gets very challenging to make sure that we are kind of building it and bringing it to that level. Within countries also, if we look at, there are relative gaps between poorer and richer subgroups for diseases like cancer, which have increased across the world regions. However, there are definitely successful models also which exist, but if we look at, let's say if we move to the other spectrum from, what we are facing, I think this is something also which is a larger problem for almost all the countries, and India is not untouched by it. And that's about the healthcare workforce shortfall. Uh, WHO itself estimated a projected shortfall of 11 million health workers by 2030, mostly in the lower and the lower middle income countries. In India, we ourselves see that, we need an additional 2.4 million hospital beds to reach the ratio of what's recommended. And if we kind of multiply or look at the complemented effect of having these number of beds with the number of people, though as far as the doctors are concerned, we are definitely somewhere there based on the WHO's recommended ratios. But then there's definitely a huge gap if we look at nursing and the specialist and the larger healthcare workforce that requires to be there. On the top of it, the increasing international migration of health workers is just adding on to these shortfalls that we are looking at. 67% of health and social workforce are women. So investing in health force is definitely an opportunity as well to create decent employment opportunities for women and youth. The third area that's a challenge is rise of chronic diseases. Uh, it's been always said, actually our chairman, Dr. Pratap C. Reddy, for the last almost 10 to 12 years, he's been saying that India is going to win a gold medal for having the largest number of diabetes and heart disease and cancer patients in the world. And this is based on true data that has been reflective. So there has been a lot of push on how can we focus on preventive healthcare, how can we change our habits, because it's just not also habits, there's also a genetic profiling to it, but largely what all can we do to make sure that we don't earn that gold medal largely. But I think there are a lot of things that need to be looked at from that perspective. In just 2018 alone, if we look at the low and the middle income countries, largely on a global perspective, they only bore the brunt of majority of 15 million premature deaths, which were attributed to just non-communicable diseases. And this burden largely falls disproportionately on vulnerable populations, where we do have these relative gaps between the socioeconomic groups for diseases like cancer, which widens all the regions worldwide. There have been innovative approaches, including the World Bank's emphasis on strengthening upstream interventions, especially the public health functions, health promotion, disease prevention. But I think still there is a long way and a long space for us to largely cover. So with these, larger issues of shortage in manpower, non-communicable diseases, disparities in the socioeconomic framework, I think it's very important that we also look at how are we actually responding to it? How are we innovating? What is a forward thinking? How the leaders are embracing it? And I think World Bank has very beautifully described it as four essential characteristics of resilient healthcare systems: being aware of the threats, being agile to that response, being absorptive to kind of contain these shocks, and then adapt to minimize disruptions. And I think if we kind of fit ourselves into that, 2x2 matrix and see how can we work around this, this essential characteristics, and what can we do as individuals, I think that's really going to demonstrate a paradigm shift and how we deal with healthcare in different countries. On a positive note, in India, though there have been these challenges, there has been also a gradual rise in aging population, increasing per capita incomes, growing health awareness, and penetration of health insurance, which is definitely driving the demand for healthcare industry in India. But I think there has also been lots and lots of digital innovations, and a lot of it being homegrown, which is helping us to drive healthcare. How do you reach out to the larger and the cornermost population people in our country, to make sure that healthcare or the right healthcare is delivered at their doorstep largely at the right time, or at least they have access to this healthcare, whether it is by telemedicine, whether it is by an application that they can just click at the touch of a button and connect with a doctor within 1 to 2 minutes. So I think there's a lot that's been happening, but as I said earlier, definitely a lot more that can largely be done. So on this larger space. So I guess that's broadly from my end on raising the questions or looking at what are the challenges that we in India are facing, and kind of summarizing it on how we are dealing with that.
Thanks very much. Thanks, Gaurav. That's really great, setting the scene of what's happening in India, and that you will have lots to discuss in your groups. I'm heading straight over to Africa now, and that's over to Lydia. And if you got any questions for Gaurav, put them into Pat chat or into the actual chat. Any questions for clarification? I haven't seen in the chat if there's any. No one's been writing chats, so if you've got anything, put into the chat so he can see it. Okay, Lydia, over to you. Let's hear what's challenges in Africa. You heard about COVID and chronic diseases, and Lydia's got a presentation, so she's going to share. Someone's going to share the screen for you. Lydia, over to you. Introduce yourself first.
Yeah, thank you very much. My name is Lydia. I live in Nairobi, Kenya. I am part of leadership for a hospital in the city that is a referral tertiary level hospital. I think I'll just share reflections now that the slides don't seem to be loading, but the facility, a little bit of my introduction is I'm also president for Society for Quality Healthcare, which is a multidisciplinary group or multi-professional that emphasizes on quality. Next slide. So the facility that I support is a level 6 hospital, a tertiary hospital that was established more than 100 years ago, but we offer specialized care. And we have implemented the ISO standard 9001, 2015, but we hope to get to a more health-specific standard in the near future. Next slide. And so we host the University of Nairobi, and allow me to pause my video so that the voice can be clearer. So we are together with we host the training institutions, that is the University of Nairobi Medical School, and a diploma level training center called Kenya Medical Training College. And so in this 2,000 bed capacity hospital, we are able to provide specialized care. And then also we are able to offer both emergency care across the specialties. And we have staff, our own staff are about 6,000, but the other facilities offer adjunct staff that provide service provision to the patient. They also support training. So we have a mix of people coming together all for patient care and training, and that at times brings with it challenges. So that's just in a nutshell who we are as a hospital. The next slide. So when we consider the topic at hand, just how complex leadership is leading people, leading self. At times it brings different dynamics in different ways in terms of what are the forces that come to require you to influence or require you to set directions. And so being ready to navigate these complex health systems. As I mentioned, in my hospital, we have staff coming from different institutions, and at the same time, we're offering specialized care, but because of not a structured referral system that is fully functional, at times we provide a lower level care. We may provide primary level care sometimes, as much as we try to ensure that we're only having those who require the specialist. And so that brings with it a lot of challenges, aspects of communications and dynamics around how we can reach to our people. Unlike very industrialized places whereby the staff are able to get communication through their intranet every other time, we are still in that dynamic of trying to reach all the players at the same time, but then also ensuring that we are able to effectively communicate our mission and vision to the different stakeholders within the hospital, managing conflicts, addressing teams, motivating them beyond their paycheck, and addressing the alignments within the organization, and also addressing the uncertainty that comes with the different models that we are having at play. In Kenya, we've had the social health insurance come and change from our previous NHIF. And so there's been uncertainty about what is covered, what is not covered. And so I think this slide is just to help me reflect on how there are multiple complexities that a leader, even in the low and middle income countries, has embracing the reforms that are coming from government, but at the same time addressing the patients who come to our doors every other time with different kind of specialties, a different kind of needs, those that require emergencies, and not all the time are the resources equal to what we have or the opportunities that we have within our spaces and theaters, having long waiting times and at times needing to communicate the availability of specific diagnostics or specific types of imaging or lab, and just working with private sector for some specialized studies, while others just accepting that this is the match that is in the package that you're offering, whether it is the health insurance that is offering, is only paying up to a certain markup or up to this number of investigations. So they in the complexity of the leader's role is addressing all those uncertainties from internal and from external, and at the same time, leading self, being able to address, to motivate self as you motivate others who may be having challenges of burnout, long shifts, and addressing even things that the union is trying to front for the rights of the workers, ensuring there's workspace safety and such. So in summary, those are some of the complexities that I was reflecting on. The next slide. So there are highs and lows. This slide was actually of something that happened 2 weeks ago, actually less than 2 weeks ago, that were in the media for having had one making history for doing some procedures, surgical procedures that were the first to be done globally and in our country. And it was a moment of celebration of what our specialists are doing. And at the same time, there was a clip that went about that the sanitary situations in some of our washrooms were not as good. And so as leaders, how do you address the momentum in that specialized care, but at the same time ensuring that we're picking up the complaints that are coming and owning, leading from the front, that on all these aspects, we lead when we are celebrating, and we lead when things are not good, turning them towards the right direction. And this is just an example. Within 24 hours, it is possible that at some point there's something on social media, a complaint, and at the same time, there's this groundbreaking procedure that has happened. And all that the leader has to address and be able to pick lessons and say, we hear, we listen, and we're doing something about it. Next slide. Another challenge, just like our brother from India has mentioned, is to do with health workforce. The middle and low-income countries are having a lot of mobility. Especially nursing staff are going to the West, and most of them are the specialized nurses, the ones we've invested time and money to train, maybe perioperative nursing, emergency nursing. We have ICU, critical care, renal. We're having a large number. In a year, we could lose up to 40 or over of specialized nurses. At times, we even get towards 100. And it is a challenge that we have to embrace by training more, but at the same time, seeing what else can we do to prepare for these transitions, and how often do we enable succession planning in those very specialized places. And at the same time, we have to ensure there is productivity. This last part of the slide has a meeting that we held just yesterday, whereby the University of Nairobi and Kenyatta National Hospital consultants were meeting to deliberate how do we address the residents who are training in our institution. But the bottom line is, how do we improve productivity among the people who come to offer care, especially the specialized, the specialists. Our CEO mentioned that we can outsource the cleaning services, and we have done that. We can outsource the security, but it is not possible for us to outsource the specialists. They need to show up. And so how do we have these knowledge workers remain accountable to the patients, to show up on time and to provide care that is safe and effective, and also to give person-centered care? And one of the challenges is waiting time. Waiting time, not because maybe the queues are long, but because maybe we are overcommitted elsewhere to show up. And so with the opportunities with locally in the private sector and public sector, and in our setting, we don't have 100% working for public only. For the specialists, they work in both. And so one of the challenges is to ensure there is accountability and patient care and continuity happening without disruption, especially for the specialized care services. Next slide. Having an institution that has been there for 100 years brings itself with challenges. There is aging infrastructure that requires renovation. Even the cost of just running the institution, I think we use about Kenyan shillings 20 million for electricity per month. And so that brings with it some weight that the leader has to see. So going forward, how do we bring efficiencies in how we manage the facility, and how do we address matters of budget cuts? Just yesterday, I think this is in today's paper, that the healthcare budget has been cut by 67 billion. And our own hospital, I think we are talking of something close to almost 4 billion cut, which is significant, and it is for the, it's something that we have to see. So how do we bridge that gap? And so aspects of finances and ensuring we are still afloat and we're still able to run. Even as public institutions, it becomes paramount that we look at looking at revenue streams and seeing how do we remain efficient and how do we optimize the finances that we have. We are still affected by other emerging issues, including climate change. We are having regulations around procurement that are changing because of climate change, and we have not even embraced aspects of waste management that can help us reduce our carbon footprint. And so as we look at these as leaders, some have cost implication, but others require just a thinking of re-engineering the system. We still desire to continue having accreditation systems that support us, and all that has cost implications, and moving the system towards embracing that well. And so there are emerging issues that we have to truly look at, and the biggest is the politics within health, and also looking at what are these reforms of health financing that are happening. And so what is wasteful? What will not be reimbursed? In what way can we reduce our losses and have patients be registered? Next slide.
We've got a minute to go.
Okay. So we have to address matters of uncertainty. You can go to the next slide, which is the last. And so basically in addressing uncertainty, we have to consider the people who are there, and addressing the people means leadership that is committed, that champions the cause, so that we are optimizing these knowledge workers that we have. We are optimizing everybody within the system, that they will all be able to do their best to contribution to what the hospital stands for. And where there are challenges, this is when the leadership needs to stand at the forefront, having clear organization goals and values, and also addressing aspects of learning from how we are performing, having data that enables decisions that are supported by data, data-driven decision-making processes, will help the institution address, be able to handle the uncertainties that come and the challenges that leadership are drawn to, and just ensuring that we do value-based leadership, and including the Gen Zs, our health workforce that are younger and maybe may need a different way of handling their challenges, so that they can have the stay power and be part of our health in the future, because we need to all grow and also be sustainable, that in the future we are having leaders that have been grown within the system and that are able to offer the care that is required. Thank you. I think I will end there.
Thanks very much, Lydia. And I've kind of summarized it onto Padlet. I'm going to move straight on to Belgium, to Mathieu, who's representing the European group of nations.
Thank you, Peter. So hi, everyone. So I'm Mathieu Louise. I'm the Deputy CEO and Head of Improvement Services at PAX. We are a Belgian organization, similar in spirit for those who know to the IHI, the Institute for Healthcare Improvement, in how we work. One big difference, we support the Belgian healthcare sector for free, helping them to improve quality. Let's talk about adversity with no slides, but just provocation to think about during those 5 to 6 minutes. Our leaders have faced it daily for years, and since the pandemic, it hasn't so much increased, in fact, for me, as it becomes more visible. Right now, leaders in Belgium mostly perceive adversity through two lenses: the financial pressure and staff shortage. And the two are locked in kind of a vicious cycle. Staff shortage reduces revenue, and low revenue worsens staffing. These are not just management problems, they are engagement problems issue. And we know, thanks to Michael West's work in the NHS, that staff engagement directly impact patient outcome, like the hospital standardized mortality ratio. But those aren't the only challenges. We are dealing with a constantly evolving world, new model of care, growing patient involvement, new generation, and the need for new leadership. So how can a leader possibly handle all this? Our answer at PAX is really bring meaning back into healthcare, restore purpose, and above all, bring back humanity in the system. I often quote with my students or when I teach in my university a Marriott motto, slightly adapted for our sector. Leaders must take care of our staff because they take care of our patient. But how do we do that? It starts with one question for us. The question is, what matters to you? Leaders need to ask that question to patient, to staff, and the organization itself should have its own what matters to us. This three pillar, what matters to you, staff, patient, organization, is for us the first step toward making healthcare kinder. Now, what do we mean by kindness, in fact? This isn't something soft or fluffy, you can imagine. Kindness in healthcare is really strategic for us. It builds human connection. It shapes culture. Did we forget that healthcare is about care, not just cure? Michael West's ideas on compassionate leadership complete the picture, the big picture. It's about creating an environment where staff can thrive and where patients receive the best possible care. So now we have a trio, what matters to you, kindness in healthcare and compassionate leadership. And this combo is urgently needed. In 2023, a KU Leuven University in Belgium study led by my friend, Professor Chris Van Acht, actual director of my actual PhD research, revealed a sobering fact. Every year between 2008 and 2018, over 4,000 people in Belgium die from adverse events in hospitals each year. Most are probably preventable. Even more telling, difference in region, hospital size, or teaching status didn't explain these outcomes in Belgium. The leading hypothesis of the research team, it's about quality culture, quality leadership, and quality context. That's why for us at PAX in Belgium, leadership is really the key. After the pandemic in 2021, we published a paper in BMG Leader with colleagues reaffirming one core belief: healthcare must be reconnected to its mission and purpose. And that means putting humanity back at the center of care. But here is the thing: leaders have to prioritize. And often I do understand that fully. They focus on the hard stuff: finance, performance, operation. It's a short-term view that might work, but what about long-term? We risk forgetting the human factors that keep the system running. If we want a sustainable healthcare system, we need to reinvest in joy at work. because when staff feel connected, supported, and valued, everyone benefits. So I will leave you with this. Let's bring back meaning in healthcare. Let's lead with kindness and compassion in healthcare. Let's ask what matters to all the people in the system. Because true leadership isn't about control, it's about connection. And that's the only way we will build a future where patient, staff, and system can truly thrive. So thank you, and I will let you with that, and I'm happy to discuss with you all afterwards.
That's great. That's really good. And I'm just going to basically just in comment on that, because as the moderator, I get that chance. There's a very good book on social capital. That's what you've been talking about. How do you build social capital? And it comes from Tom Lee, who's giving the keynote, one of the keynotes at the IHI forum next week. And that's what you were talking about there, Mathieu. How do you build social capital? So that you might want to discuss in your groups. Okay, we're going off to Juan in Peru, and welcome, Juan. And you've got a number of roles you can introduce yourself to. So I'll give it over to you for the next 5 to 10 minutes.
Hi everyone, I'm Juan Limo. I am internal medicine specialist, and I'm passionate about leadership in quality and safety, teamwork, communication, and so forth. Very happy to be here, and I want to share some ideas and experiences, and let me share my presentation, please. Great. Great. Well, in Peru, are suffering several changes in healthcare. Previously, in COVID-19 pandemic, and we are really struggling with disparity, with technological issues. In fact, sustainable financing is a very hard issue that we are suffering, and right now we are some of emerging diseases that are appearing because several factors. And 5 years ago, we had extreme conditions, floods, very rainy conditions that affected our healthcare system. But I just remember and show you about interesting paper published in 2007 about a study about severe acute respiratory syndrome, coronary virus as an agent of emerging infection, published by Vincent Chen from Hong Kong. This paper showed us about the concept of risk awareness. And in this paper, the last paragraph told us about the importance of be prepared for the future. Coronavirus are well known to undergo genetic recombination, which may lead to new genotypes and outbreaks. The presence of a large reservoir of this kind of viruses in horses' heads, together with the habit of eating exotic mammals, in the possibility of the emergency of SARS, told us about the need of be prepared for the future. Probably few people take account this paper. So confronting adversity, involves leadership in crisis. And the first thought that I have is about we need to see the big picture, the whole landscape, with a system approach. But I also ask myself, how best are we prepared for the emergency condition, for the adversity? Because in that case, we need to are in conditions to keep every system operating with collaboration and mitigate losses in all the healthcare system. And how are leaders responding to challenges in healthcare? Now in Latin America, we have several outbreaks about measles, pertussis, yellow fever, dengue. So we need to deploy agile measures, agile, with no bureaucratic barriers, with no out-of-date plans. We need to tackle digital disruptions, blackout, as the last blackout in Europe, IT system failure that will affect our continuity of care, cyber attacks. So we need to have contingency plans. And every public health crisis requires a huge effort, collective effort, with team of teams. And the first thought that we had in pandemic is the need of confront workforce shortage. So we need to reallocate, to look for new people, to have the best amount of people working to maintain the continuity of our healthcare. Always thinking about that the people are in need permanently, with wellness, with emotional support, with every operative need as EPP, for example. So what kind of leadership is needed in this kind of adversity, complexity situations? Because these kind of problems are wicked problems, where there's no answer, there's no easy answer to this kind of problems. Many solutions are costly. These problems are difficult to define, are several issues interconnected, and solution may cause new problems. So we need to deploy with adaptive leadership. That is the practice of mobilizing people to tackle tough challenges and thrive, especially in times of uncertainty and change. Several issues in adversity are not technical, are adaptive. There's no easy solutions. So we need to consider this, and important style in leadership, that is transformational style. that elevates and inspires people motivation to make things in order to achieve transcendental goals. That is, we need to have individual consideration because people are different. We need to serve as a model roles. We need to influence positively. We need to recruiting people with hope and with purpose based on our vision of future. So we have to deploy a really robust governance and leadership practices. We need to make an effective communication to bring to people, to leaders, to teams, and have the right coordination in mobilization. But the most important factor, in my opinion, is resilience. In resilience, I want to show the work of Professor Eric Holnagel, in that she teach us about the importance of have a strategic, high-level planning process, because the degree of our capacity to anticipate and respond will depend upon this level of strategic planning. If we don't have operating or planning or operational processes working effective, with capacity of effective response, if you don't have this, we probably we want to have the capacity to anticipate and learn and have a and succeed into this kind of situation, adverse situations. And I also want to share this kind of concept of team of teams, because in the middle of the adversity, we usually struggling to lead, to organize, to coordinate. So Stanley McChrystal teach us about the need to leave the command and control style leadership practices to a new model about the team of teams, in which every team cells are interconnected, are coordinating, are leading at the same level, all about the situation, all about the difficulties and the communication, and especially to make the work in adversity more feasible.
1 minute, Juan.
Yep. And in this one will lead us to have a network in capacity to respond appropriately, in which two kind of framework, a team leadership, which always should be directing the response, and several other teams in charge of communication, financial, supply chains, technology, and so forth. Well, thank you very much. From New Medical Leaders, our purpose is contribute to development of clinical leaders to lead to the positive impact into quality and safety and patient experience. Thank you.
We were talking about the impact of colonialism on the health structures in Kenya. So I had a message from Neil telling me what he spoke about. He listened to the rules of the facilitators and put into Padlet. So I know what Neil's group said, talking about a workforce and developing a workforce and moving on from the WHO to be a resilient workforce. I think that was the key message from your group, Neil. Is that correct? And I think that's essential. That came out of all the talks, the importance of resilience. Juan spoke about it, Lydia spoke about it, and retaining work. So I brought up the point of the importance of us in the upper income countries not being scavengers and taking the best out of the lower income countries. And we really need to think hard when we go recruiting in the different areas. I know the health service in the UK would collapse without the Philippines or without people from the subcontinents, either Pakistan or India. So that's the one thing, the workforce, that came from Neil's group. Our group was talking about the colonial heritage and how that impacts on healthcare and how it was structured and even leads to current disparities.
So we were talking about kindness quite a bit, and I guess we sort of ended the discussion thinking about what the experience is like for people kind of coming into the workforce and their expectations of what work and their experiences, particularly working in healthcare, should be like. And we talked a little bit about like the mechanisms that have been used in Belgium as well, in terms of asking the what matters to you and actually making that I guess an expectation of both patients, but also of healthcare professionals to actually ask that question and consider that in terms of what they do and their interactions with patients and with staff.
So there were two broad themes. One really was around what do leaders focus on and how do we address local challenges? And the second one is, are there generalizable elements that resonate with all of us? And that really speaks to the importance of context. And the second theme was what specific actions leaders could do. And really, this is around translating things which sit around concepts and how do you take them into concrete actions. So concepts like systems leadership, concepts like how to be kind and compassionate, but what does it actually look like at the ground level? What do you do when you are, in the times of crisis? I think one of the participants used the word kindness in complexity. Like, what does it mean? So I think those are the two broad themes from our group.